So abscess management, you might think, geez, what could have changed? You stick a knife in it, you drain it, you're done. And hopefully I can convince you that, in fact, that probably is where we are, but we'll look at some of the evidence around this stuff and some of the other pitfalls that are there and what some of the literature says. First off, in terms of the cause of abscess, that has really changed a little bit in that it is now almost all community-acquired MRSA. So we went through a period in the United States where those numbers were 20%, then 40%, then 60%, and now many places are well up above 70%, where community-acquired MRSA is the cause. Many of these patients come in initially because it hurts, and they say, I have a spider bite. And we all laugh at them and say, it's not a spider bite, it's, you got this infection. And they're not crazy, by the way. The reason it hurts is because in the genetics of community-acquired MRSA is this gene locus called the PVL gene locus, the pantine-valentine leukocidin locus. And what that does is it produces necrotizing extracellular stuff that hurts. That's what, they've all had infections before, but they never hurt like this. They got this little pimple like, this hurts, it must be a bite. And that's what they think, and then eventually it becomes a cellulitis. The other thing about this organism is many people are sort of colonized with it. I've been intermittently colonized with it. I work at a hospital that sees a lot of homeless and indigent patients. We're a high MRSA sort of area. And so healthcare workers get it if you've had that infection on the back of your neck. That's from your stethoscope grinding the MRSA into the hair follicles on the back of your head. And one of the things about this slightly more aggressive, nasty organism is it's really pretty good at generating furunculitis. So the number of, remember the old days, you have an abscess, you stick a knife into it, and it's like the volcano. And you don't have to do much more. There's no fishing around necessary. It just drained. Now you stick a knife into it and not much comes out. And there are loculations in there, and that's because this thing started as a couple of furuncles. They're loculated. So now one of the things that's changed with this organism is it's not just I&D, and I'm a broken record with our residents, is that it takes a little more effort and a little better pain control because it's I&D and D, incision, drainage, and debridement. You got to go in there and get the jam. If there's that fibrous, loculated thing in there, that's got to go. If there's an eschar on the surface of these things, you'll see some of these people, little black eschar, it's got to go. If you see them with you'll see this little pimple with this like sort of sunburnt area where the skin is peeled back. What is that? That's PVL. That's a little necrotizing factor causing that skin to peel back. So clinically, you'll see this. Let's talk a little bit about just community-acquired MRSA versus hospital-acquired MRSA, because they aren't the same thing. So community-acquired MRSA, nasty organism, necrotizing features, but not terrible resistance patterns. If you were to send a culture, and I'm not telling you to, we're going to look at the literature that says don't, but if you were to send a culture and sensitivity, what the sensitivity would look like would be S, 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 R, R, I, S, S, I. So there'd be a resistance or two, there'd be an intermediate, but it'd still have pretty good sensitivity. As opposed to hospital-acquired MRSA, which is a bulletproof staphylococcus bred in the ICU, where it's been lathered with antibiotics for months, that sensitivity, when you get a hospital-acquired MRSA, is R, 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 go ahead, give it up, asshole, R, 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 I, S. And the S is to something like, gorillamycin. So hospital-acquired MRSA is a nasty, multiply resistant organism, but it doesn't have the PVL. It's not as necrotizing. Community-acquired MRSA is a necrotizing organism that has still a fair amount of drug sensitivities available. There are choices to be made. One of the things about this community-acquired MRSA, because it's a little nastier and has this PVL, we've seen an increase in incidence of skin and soft tissue infections over the last decade, 15 years, of about threefold. I think that's no surprise to anyone in the room. Are you seeing more furunculitises and more abscesses than you used to? I think the answer is yeah. I mean, there's a spider bite a day in most ERs that's, one of these MRSA furuncles. So the incidence is increasing. And after you I&D them, I think we'll get into these questions. Should they be packed and those types of things? So let's go to the literature now and see what they got to say about it. But I really would emphasize that if you want to do this right, it's I&D plus D. If there's a necrotic eschar, it's got to go. If there's that knot of fibrous junk in there, it's got to go to adequately have IND these. These are harder to IND than the abscess of old. All right, first paper is one of these overview papers in current infectious disease. A lot of times when they write one of these papers, what it's really about is not to tell you any breaking news on the management of abscess. It's to announce the origination of some new really expensive drug. And that's sort of the case here. They want to tell you about daptomycin. They also want to tell you that there's this new rapid PCR test that you can do that'll give you a turnaround time of an hour to tell you that it's community-acquired MRSA, as if you didn't know. So I don't know what the utility of that is. And there's some papers about ultrasound there, and it also talks about the 2 to 3-fold increase. So not much news there. Papers 2, 3, and 4, I think, are kind of important. You see someone with a cellulitis, is it an abscess? And can you reliably tell? So we all know we were taught to go, poke around on it with your fingertips and use your sense of feeling to identify if there was fluctuance. And if there was fluctuance, that suggested an underlying fluid-filled space from which the pus should be freed. The problem is that with community-acquired MRSA, some of these cellulitises, it's not clear whether there's an abscess underneath it or not. And so we have abstract 2 by Mallon in 2010. This is 371 lesions in 349 kids where they asked about, clinically, is it a cellulitis or is it an abscess? And the kappa values among 2 different docs looking at them, kappa as a measure of agreement, was low, about 0.4. That means that a lot of times I thought it was an abscess and you didn't. So it turns out that the clinical reliability of determining whether it's an abscess is not that great. And obviously, if you send an abscess out on antibiotics, do abscess get better on antibiotics? No, they need to be drained. So it's a pretty big and important branch point. And so abstracts 3 and 4, and 3 I like a lot. It's not a huge study, 126 patients. They said they took an ultrasound using the TEG 10 megahertz linear high-frequency probe, and they just scanned over their red area and said, is there something black underneath there that suggests a fluid collection? And they were surprised that, in fact, many things that they thought were just a cellulitis had actually a fluid collection underneath them, and it changed the management in half the patients. This is pretty much routine at our hospital. We do this for any large territory. Anything, a furuncle. I'm not saying you should scan a furuncle, someone with furunculitis. But if they've got a territory of cellulitis and you're not sure, you see something in here. Last I checked, in here is abscess territory. So it looks like a cellulitis. You can't feel anything fluctuant. I would highly recommend scanning that and taking a look to see if there's a fluid collection that you should go after. And abstract 4 says if you do that, you'll have improved accuracy, and I'm a believer of that as well. So I think that scanning to look to see if there's a fluid collection is a useful thing to do, because when there is, if you don't drain it, they're not going to get better. All right, should we culture them? One of the things is my pet peeves is I show up for a morning shift and I walk through the waiting room and it looks blissfully good. And I'm thinking I'm going to actually have a coffee and some time to talk to the residents and do some teaching. And then some nurse walks up to me with will you please contact these patients with their culture reports? I'm like, what? Who cultured that sore throat, for God's sakes? Don't culture the sore throat. And I know the PEDS people recommend it, but most people don't recommend culturing sore throats. Like a positive culture to sore throat doesn't mean they have it. A negative culture doesn't mean they don't have it. Anyway, I can't imagine why you do a culture and sensitivity, which costs almost $300, when the treatment of sore throat costs $7. And you were going to plan to treat it anyway. Just treat it. But in any event, I digress. Why would you send, one of my rules is outside of maybe CSF or synovial fluid, which are sort of hard to get a hold of, you went to the trouble to suck some juice out of the peri-brain space, by all means culture that. Turns out it looks like viral meningitis and they're going home. Sure, I'll check that to make sure it's negative. That makes sense. A synovial fluid, same thing. But you drained an abscess. Don't culture it and bother me with it in the morning, please. So abstract 5 from Stevens says, a normal immunocapable host with a simple, uncomplicated abscess, no cultures. It says, yes, if there are host factors that worry you, they're HIV positive, they're post-chemo, they are on steroids for their rheumatoid, by all means, knock yourself out. So if you want to send cultures because it's an immunocompromised host or there's something concerning about it, sure. But on a regular old run-of-the-mill normal person with an abscess, no cultures. Abstract 6 has reserved cultures for failures and recurrences, and Abstract 7 from ASAP, 2012, says simple uncomplicated abscess, IND, no cultures. Please don't culture these. We know what it is. We know the name of the organ. It's Bob, the community-acquired MRSA. Bob looks like a spider. We know it. We know who it is. How about, should you be sending, you got a person, you're going to IND and send them home. Should you lab them up? That probably don't have, a positive troponin. So this paper's, they start looking at it. 8 is a look at 17 studies with pretty lousy methods. But it says these labs that you might do, things like a CBC, a WBC, an ESR, cultures, other things, they're rarely positive, and when they're positive, when it pertains to the organism, they're usually consistent with the empiric treatment that was going to be chosen. Don't do them. 9 is a pediatric paper, kids with uncomplicated infections and skin and soft tissue infections. This talks about blood cultures. I love all the places they ask for blood cultures. You got a pneumonia patient, let's get a blood culture. Excuse me, doesn't pneumonia mean the infection's in the lungs? Why would I look in the blood? When I think it's in the blood, we call that sepsis. You think they're sepsis, they're toxic, they're sick, you're admitting them to the hospital, fine, get a blood culture. But you're gonna IND something and send it home. Why on God's green earth would you send a blood culture? Last I checked, in this disease, the skin is the place of the infection and maybe some of the underlying fat. So blood cultures, no. Abstract 10 says the cost of cultures is high and the yield is low and you're not gonna change your empiric therapy anyway, don't do it. And the 2014 Infectious Disease Society of America guidelines are no cultures in uncomplicated skin and soft tissue infections without systemic findings. In other words, they don't look like they have sepsis. You're not talking about starting a line on them and admitting them to the hospital. No cultures. So I think we're there. No cultures on the simple ones. How to IND. We got a couple papers. Could there be anything new about this? Well, we talked about it. You got to open it up. You got to break up the loculations, get rid of the dead stuff, do the debridement. But some people have said, and I see this all the time, I got residents who want to do this all the time. Do I really need to IND that? What if I just needle aspirated? Isn't that going to be good? I don't get most of the pus. Isn't that going to be adequate for them without slashing them open and doing things? No, is the answer. No, it's not adequate. When you need to free the pus, you need to free it in a robust and energetic fashion. Free the pus. Cut a hole in it. And if you want to put the rope ladder down there, the cargo netting, the packing, so that the bacteria can crawl out like Marines making an assault on some beach, then do that. But you got to IND it. When you looked at aspiration, ultrasound-guided aspiration, the failure rates, resolution of disease at 48 hours was not as good, and the failure rates were alarmingly high. Overall failure rates, 20% for IND versus 74% for aspiration. So aspiration, resist the urge. If you found a fluid collection, open it up, free the pus. Abstract 12 is an Adam Singer paper. For those of you who read our literature regularly, there are a few people like Adam Singer and Judd Hollander who you're like, how do you do it? I mean, they're publishing 50 papers a year. But anyway, here he looked at this and his conclusions regarding simple abscess. Sure, ultrasound, yes. IND is the standard of care. But what about primary closure? You drained it, now we're going to sew it closed. I just said freeing the pus is where we want to go. He notes that there's a few papers that have talked about it, not usually emergency department patients, but he looked at it in this small thing and said, well, maybe primary closure is okay. Am I doing primary closure on any abscesses? No. Anyone doing this loop drainage thing? So the residents love that. It's a new thing, and it makes kind of sense to me. So you make your primary incision where the heart of the abscess is, and maybe you make another stab sort of where the backside is. And then what you do is you put a catheter through that and tie it on the outside. So you make a little knot so there's room for it to come out. It's kind of like a double IND with a loop to make sure that the thing stays open. And so there's Abstract 13 talks about it, and it's a small paper. It's not good enough to say it's fabulous. N equals 219 here. But the loop approach had 0 recurrences, and IND, who knows how vigorous the INDs was, had 4 recurrences and 1 incomplete resolution kind of thing. And so it's a paper by someone who's enthusiastic about this technique and did it. I got no problem when the residents want to do it. I'm fine with that. You want to do the loop thing, that new thing? Sure, knock yourself out. Pack or not to pack, traditionally we've been taught you have to pack these, put in the cargo netting so they can make their way out. Packing's a little bit painful. I see people overpacking stuff all the time. They're like jamming shit in there, like, get the plunger. I'm like, don't do that. I mean, isn't it bad enough that you had to lance this thing on them already? I mean, just take it easy. If you're gonna pack it lightly. Don't jam stuff down there. But these papers all say things like, like 14, probably unnecessary is in the title. Now, N equals 48 there. It says no packing, less pain. It probably doesn't help that much. Abstract 15 says, particularly in peds where removing the packing might be just as traumatic as the first event of INDing it. Maybe you could do without. And it's 100 healthy kids, follow up at 7 and 30 days. They treated them all with Bactrim, so they added antibiotics to the IND and then didn't pack. So what I really want to know is no antibiotics, no packing. How did that work? This answers antibiotics plus no packing. Slightly different from the question I really wanted to do, but they reached the conclusion that wound packing offered no benefit. Primary closure again, abstract 17 is a paper that looks at it from Adam Singer again, and says primary closure, more rapid healing, and we'll have to see what happens with their recurrence rates, and I'm, like I say, I'm not there yet. And 18 is where he actually did a prospective trial. I don't find the results that impressive. Now the questions you really want to know about the antibiotics, because it's very tempting. You see an abscess, you IND it. Is it really a cellulitis plus an abscess, or is it just the abscess? And every abscess you expect to have a sort of a red roof on it and a little bit of redness around the periphery. How much do you accept before you call this a cellulitis with an abscess? And I think if there's just, anywhere from 3 or 4 millimeters to maybe a centimeter of redness around it, it's probably just an abscess. You tell me you got a lymphangitic streak or there's a smear of redness moving away from the thing, you want to call that a cellulitis too, I'm fine with that. So now the treatment with the antibiotics is not for the abscess, it's for the cellulitis. But please make sure that the finding of cellulitis is real, and let's not lie about what was just an abscess. Because if it's just an abscess, the papers say IND alone. So 19 is is a review by Hankin in 2007, 5 studies. This was when the MRSA rates were still a little bit lower, so that's why it's a little bit of a moving target. In this paper, the MRSA rates were probably around 50%. But at that rate, when they looked at 5 studies, the findings did not support antibiotics in addition to IND for a simple, uncomplicated abscess. 20 by Duong is a randomized controlled trial of abscess in pediatrics that again found that antibiotics don't help. And who did they say you would give antibiotics to? Well, all the things we said, when it's not just an abscess. They look toxic, you think they're septic, give them antibiotics. You think they're elements of SIRS, immunocompromised, there's multiple recurrences, they've had a failure of treatment, by all means, tack on the antibiotics. But common sense sort of ideas there would guide you for which abscesses need antibiotics, and underlying it is the concept that the vast majority of simple, uncomplicated abscesses do not need them. 21 is one of these papers that notes that there's been a 2 to 3-fold increase in skin and soft tissue infections. Talks about the antibiotics used. If you were going to use antibiotics, please target MRSA. And so it would be Bactrim, maybe doxycycline, maybe Clinda. 22 says, you can go with the antibiotics if you want. 23 is a paper that says, we gave our abscesses the wrong antibiotic and they still got better, which is evidence that the antibiotics didn't help, not evidence that you need antibiotics. And so there's a bunch of papers there. So our standard, and you might imagine in a hospital that services something like, I don't know whether it's 13 or 14 sort of mission and homeless centers in downtown LA, though they're all in our catchment area. So you can imagine, you know what these people look like, right? Their jeans are soaked with urine, at least one pair that they're wearing. They're often wearing 2 or 3 pairs of pants. You take their socks off, some unbelievable odor comes out from them. So these are people with lots of these skin and soft tissue infections. And our practice with most of those is to do IND, pay a lot of attention to appropriate wound care. If you need to add more PSA or nitrous oxide or some adjuncts so that you can do a good, thorough job. If there's debridement that needs to be done, do it. And then we don't start them on antibiotics. However, if they have a true sign of a cellulitis with ascending lymphangitis, lymphadenopathy, things like that that worry you, then we do. And we use Bactrim on the vast majority of these. If they're sulfa-allergic, we'll sometimes do Clinda. I will tell you that we know a lot about the genetics of community-acquired MRSA with regards to Clinda, and that is that community-acquired MRSA has inducible resistance to Clinda. That means that there are well-documented cases of people who were started on Clinda for an infection that was sensitive to Clinda, according to the initial cultures, who were resistant to Clinda by the end of a single round of treatment. So with Clinda, resistance can develop really fast, so you need to know your local antibiograms if you're going to be choosing Clinda. You also have to worry about the other GI aspects of Clinda and things like that, C. difficile and things like that. Now at the end of this, there's a couple of papers about things like dog bites and who needs antibiotics and their management. And let's just talk just for a few minutes about dog bites. There are some places in medicine, we talk a lot about the bell curve, we talk a lot about the logarithmic curve, but we don't talk that much about the bathtub curve. And dog bites are a really great example of the bathtub curve. So if I put all dog bites on down here, and here are the minor dog bites, and here are the severe dog bites. And some people even die from dog bites. There's the scale. And over here I put frequency. Well, at the minor end, there's a really high frequencies of dog bites where the dog is either defensive or snapping. It's not really attacking you, it's defending itself. There's a huge number of those snaps, yippers, one of these quick yips kind of thing. And then there's almost no dog bites in the middle. Almost no medium severity dog bites. And then you get to the high end, and these are where you have inadvertently become inserted into the food chain with a dog that means business. And some of those are deaths. So the law enforcement dog bites are all over here. The thing where there's 3 dogs and a kid are over here. All that pit bull, Akita stuff is over here. Nothing in the middle. So the vast majority of dog bites you're going to see are down at this low end, where there may be a tear in the skin and they present for wound care plus or minus sutures. And many of these do not need antibiotics because there is not a lot of crushed, devitalized tissue there. It's a matter of, if it's a puncture wound that you can't really clean out, fine, put them on antibiotics. It's the whole thing. Dog bites, get Augmentin. Many people treat every dog bite they see with Augmentin, and I think that's overkill. So if it's a simple, uncomplicated wound that you can do a good job washing it out and wound check, I don't think they need to be on antibiotics. If it's a puncture wound down on the minor side and you can't really wash it out and you would have put it on Augmentin, fine. Down here, when you get over to this side, where there's crushed, devitalized tissue, pieces missing. When you look at law enforcement dog bites, if you're a taxpayer, for example, we have a jail ward at our hospital, and we did a series, Deirdre Anglin published a series of 700 law enforcement dog bites. And law enforcement dog bites are a completely different deal, right? These are animals with routinely 900,000 PSI bite strengths. If they want to crush both bones in your forearm, they can easily do it. And they take pieces off you. The people come in having had a law enforcement weight loss program. They need plastics, they need wound care, they need to go to the OR, they have crushed devitalized tissue. All of those people need antibiotics. But it's mostly because of the nature of the wound. Crushed, devitalized tissue, major trauma associated with it, pieces missing, wound care issues, plastics issues, they get antibiotics. 100% of those get antibiotics. But down here on the minor side, the other edge of the bathtub with the minor bites, I think there's a lot of room for discretionary use of antibiotics. If it's a little the most common thing you see is this V-shaped wound where there's a little flap. And you can wash that out and clean that up and tack that down carefully. Should you close that on the face? I would close that on the face. It's of cosmetic importance. I'd wash it out, clean it up, close it. You could decide then at that point, do you want antibiotics or not? And so use your judgment on these, but I think the idea that every dog bite needs Augmentin is really, really quite challengeable. And that takes us to the sort of last point that you'll hear all the time, which is, well, cat bites are more infective. You're talking the Pasturella board question. Cat bites are more infective than dog bites. Probably not. It's just that all the cat bites that are infected come to the ER. So almost virtually every cat bite you see that comes to the emergency, because they don't come for wound care, they only come 2 to 3 days later when it's infected. So of course, if you start with a denominator of cat bites that came to the emergency room, the percentage that is infected is like 100%. But if you took all cat bites, including the ones that didn't come to the emergency room, which there's a huge number of them that never come to the emergency room, they're not infected. So yes, cat bites and dog bites, you're worried about Pasteurella. The idea that cat bites are uniformly more infective than dogs is probably false. We don't have good numbers to say that, but it's probably false. And every once in a while, you'll see a cat bite, and I saw one, it's about 6 months ago in the emergency room. She'd been bitten on the hand, on her finger. Have you ever seen that thing on the web? Have you seen the image about how to pet your cat and how to pet your dog? Oh, you got to look at that. Just look that up on the web. The dog is, everywhere you touch it, the dog is like, oh, yeah, oh, great, yeah, oh, good. The cat is like, and on the belly of the cat, it says, fuck you. So people who don't understand this, who think that their cat wants a belly rub, get bit or clawed. And this lady, so she'd been seen, and they went and they put her on Augmentin, and it didn't do better because it was a puncture wound, and it really, was a problem. And then 4 days after that, or 5 days after that, she represented, and now it looked really bad. She had a cellulitis going up her hand and both sides, and she was having a lot of pain, and that she was uninsured, and that doctor realized, boy, this looks pretty bad. We're going to change your antibiotics because my orthopod's not taking care of you uninsured. But by the way, I recommend you go to the county. So she didn't take that recommendation for another 5 days, so she came to us 10 days out with a raging flexor tenosynovitis with all of Canaveral signs and a gigantic lymph node. And the reason I tell the story is just to remind you of cat scratch. So she was the rarely seen in active competition cat bite that gave her both, and she had some claw marks on the back of her hand, it gave her both cat scratch and FTS. So it happens.